Hello everyone, welcome to another lecture in my cardiology series. Today we'll be discussing the very important topic of heart failure. My objectives for this lecture are for you to be able to know the definition of heart failure, to understand the methods we use to classify heart failure, to use clinical and laboratory methods to diagnose a patient with heart failure, to understand how to manage chronic heart failure, and to recognize the entity known as acute decompensated heart failure or heart failure exacerbation, its etiologies, and to apply appropriate management strategies based on the patient's clinical phenotype. Before delving into a discussion of heart failure, it's useful to review some important hemodynamic concepts that come up in the discussion of heart failure. Preload is the force of stretch applied on a muscle just before the start of contraction. So in the context of the heart, that would be the stretch in the cardiac myocytes just prior to the start of a contraction, which would be at the end of diastole, just before the start of systole. And that would be very closely related to the end diastolic volume in the ventricle. In contrast, afterload is the force that needs to be generated in a muscle in order to actually do work. For example, if you were to be lifting a heavy box off the ground, the afterload is essentially the weight of the box, which is the force that your muscles would need to overcome in order to actually start doing work and lifting the box up. And in the context of the heart, that's the force that the ventricle needs to overcome in order to actually start pushing out blood into the aorta. The cardiac output is the rate of volume flow of blood generated by the heart during a contraction, usually measured in liters per minute. It's equal to the stroke volume times the heart rate. And an important equation that comes up in cardiology and hemodynamics is that the mean arterial pressure, it's the average pressure in the aorta throughout a cardiac cycle, minus the central venous pressure, which is typically the pressure in the right atrium, is equal to the cardiac output times the systemic vascular resistance. Here's a useful graph displaying the pressure in the left ventricle as relates to the volume in the left ventricle during a cardiac cycle. Starting with the gray curve or loop, and at this point, when the left ventricular volume is at a minimum and the left ventricular pressure is at its minimum, this is the point where the mitral valve opens and blood starts to fill from the left atrium into the left ventricle during diastole. And the volume in the left ventricle slowly rises with a very slight increase in the pressure. The slope of this line reflects the compliance of the left ventricle during diastole. At the end of diastole, the mitral valve closes, and the ventricle starts contracting with a fixed volume. This is isovolumetric contraction. And the pressure in the left ventricle will rise all the way up to until this point, which is the point at which the left ventricle is able to overcome the afterload and start pushing blood out into the aorta. So this is the point where the aortic valve opens and blood starts to leave the left ventricle, so the left ventricle volume decreases all the way up until the point where the pressure in the left ventricle starts to drop below the pressure in the aorta. At this point, the aortic valve closes and the left ventricle starts relaxing with a fixed volume until the mitral valve opens again and the ventricle can start filling. So the volume at the end of diastole reflects the preload, and essentially the pressure that the ventricles have to generate to overcome the resistive forces and start actually pushing blood outward is the afterload. Now let's look at the red curve or loop. This is could be a case of the same patient after receiving a fluid bolus. In this case, as a result of the bolus, the left ventricular end diastolic volume increased from here to here. And as a result, the stroke volume, which is the difference between the end diastolic pressure and the end systolic pressure, increased in this red loop compared to the gray loop, as seen by these arrows here. This reflects a very important principle called the Frank-Starling law of the heart. And it's essentially a description that the more preload you'll apply in the heart, the stronger the contraction of the heart and the greater the stroke volume. This is related to the fact that increased stretching of muscles helps to align actin and myosin filaments better and resulting in stronger contraction. With an understanding of this, we can talk about the definition of heart failure. Here we see a graph of the stroke volume of the heart as a function of the left ventricular end diastolic volume or preload in the left ventricle. As we discussed, the Frank-Starling law states that the more preload you'll apply inside the left ventricle, the greater the stroke volume that would be generated. And so you see essentially in the beginning a linear relationship between the left ventricular end diastolic volume and the stroke volume. Healthy hearts are able to maintain this relationship for a long period of time, but the weaker the heart gets, it's eventually plateaus off, where further increases in end diastolic volume no longer generate noticeable increases in the stroke volume. And eventually these curves will start to drop off, where further increases in preload actually lead to decreases in stroke volume, where the heart is stretched beyond the point where it can efficiently generate contractions. Heart failure itself is a clinical syndrome characterized by a certain set of symptoms, which include decreased exercise tolerance, the presence of pulmonary or peripheral edema, and shortness of breath. These symptoms are attributable to a structural heart abnormality or a cardiomyopathy that either impairs the ability of the heart to perfuse the body or causes it to do so only with elevated intracardiac pressures, which would lead to increases in the left ventricular end diastolic volume or preload. So if this curve represents a normal heart, this patient can generate adequate stroke volumes at fairly low levels of end diastolic volume or preload, whereas if this curve representing the patient with significant heart failure, in order to generate the same level of stroke volume, they would need much higher levels of preload. If the cardiac function became even worse, you can depict that with this blue curve here. This patient would never be able to achieve the same level of stroke volume as the other two patients, regardless of how much preload the heart was getting. So why is heart failure such an important topic? Well, heart failure is thought to be a disease that will affect around 20% of Americans at some point in their lives. It has an incidence of about 650,000 new cases a year, as reported by the American College of Cardiology, or ACC. The prevalence would be greater than 5 million total cases. in the country. It's a very leading cause of inpatient admissions and readmissions, which creates a huge economic burden on our healthcare system. And it's been such a huge economic burden that the American Heart Association recently put out an initiative called Get With the Guidelines, where hospitals are asked to audit the management of the patients with heart failure to make sure that they're on the right evidence-based therapy to increase and maximize their chances of improving their symptoms and preventing readmissions. And so that's where the role of the clinician really comes in, by understanding the guidelines, understanding the best evidence-based management of heart failure. We can reduce the chances that our patients will get readmitted and significantly reduce their morbidity and mortality. A huge part of properly managing and applying appropriate therapy to our patients with heart failure is understanding exactly what type of heart failure they have. And there's at least 3 major classification schemes that we use to describe a patient's heart failure. One is by the patient's ejection fraction, in which case we can classify the patient as having reduced ejection fraction, heart failure with reduced ejection fraction, or HFrEF, heart failure with preserved ejection fraction, or HFpEF, and a third category called heart failure with mid-range or intermediate ejection fraction. The choice of therapy is greatly influenced by the patient's ejection fraction. We can also classify our patients by their functional status or prognosis, and for this we have the NYHA and ACC scoring systems. And then we have the underlying cause of the patient's heart failure, the pathophysiology or etiology. And these are the various cardiomyopathies or structural heart defects that are thought to be causing the patient's heart failure. Starting with ejection fraction. Ejection fraction is defined as the stroke volume divided by the left ventricular end diastolic volume or preload. So it's essentially the volume of blood that's ejected by the heart in a single cardiac cycle compared to the amount of preload that the heart needs to generate that stroke volume. And this is usually expressed as a percentage. So the patients we classify as having heart failure with reduced ejection fraction, or HFrEF, these are the patients with an ejection fraction less than 40 and who have clinical symptoms suggestive of heart failure, such as those we discussed previously. It's important to recognize this because most of the evidence-based heart failure therapies that have been developed are proven in specifically for the patients with HFrEF. Heart failure with preserved ejection fraction refers to those patients with an ejection fraction greater than 50% and clinical symptoms, in addition to other markers such as elevated natriuretic peptides, which indicate that the heart is under strain and requires elevated pressures to generate adequate cardiac output. They'll also have evidence of structural heart disease on an echocardiography, such as LVH, left ventricular hypertrophy, or diastolic dysfunction. And finally, we have our third category with mid-range ejection fraction or intermediate ejection fraction. These are the patients with clinical symptoms and an ejection fraction between 40 and 50%. The functional classifications, we have the NYHA classification system. Class 1 are the patients whose heart failure symptoms are not limiting their physical activity at all. Patients with NYHA Class 2 have heavy exertion, such as significant exercise, limited by their heart failure symptoms. In Class 3, ordinary activities of daily living are limited by the patient's symptoms. And Class 4 are those patients who have symptoms even at rest. The ACC staging system is a prognostic indicator. Unlike the NYHA class, which can improve or get worse as a result of medical therapy, the ACC stage of the patient is progressive and only moves ahead, never backwards. Patients with stage A are those patients who actually don't have heart failure, but have risk factors and no structural abnormalities as seen on imaging or echocardiography. Patients with stage B have structural abnormalities on imaging, but do not have heart failure symptoms. ACC stage C, which encompasses most of the patients who are admitted for heart failure. These are the patients who do have symptoms that are responsive to medical therapy. And patients with ACC stage D have refractory symptoms that typically require more advanced interventions, such as left ventricular assist devices and potentially even cardiac transplant, which we'll discuss later. Last but not least, there are the classification system that focuses on the underlying etiology of the heart failure. This is very important because it does significantly affect management. We can divide etiologies of heart failure into those that are associated with reduced ejection fraction and preserved ejection fraction. Reduced ejection fraction, by which I mean an ejection fraction less than 40%, accounts for about half the cases of heart failure, and it can include causes such as ischemic cardiomyopathy, which is usually due to coronary disease that accounts for 30% of total cases, which is most of the cases of reduced ejection fraction. Drugs and toxins account for 5 to 10% of total cases of heart failure. Those include alcohol, cocaine, and methamphetamine, as well as prescription medications, including chemotherapy agents like doxorubicin and steroids. Tachycardia-induced cardiomyopathy is an entity associated with arrhythmias such as uncontrolled paroxysmal atrial fibrillation or atrial flutter. The remodeling caused by these arrhythmias leads to decreased ejection fraction over time. Although hypertensive heart disease generally leads to concentric hypertrophy and remodeling of the heart with a preserved ejection fraction, rarely and over time with uncontrolled hypertension, eccentric remodeling will lead to decreased ejection fraction. And so a small subset of patients with hypertensive heart disease will have reduced ejection fraction. Other rare causes will include infectious etiologies, such as myocarditis, which can be due to parasite infections, as in Chagas disease, or viral causes of myocarditis. There's Takotsubo, or stress cardiomyopathy, where a portion of the left ventricle becomes aneurysmally dilated, leading to a reduction in contractility. And there are the inherited disorders, such as arrhythmogenic right ventricular cardiomyopathy or non-compaction cardiomyopathy, where as a result of a genetic defect, the myocardium fails to form organized muscle and instead forms this spongy, textured tissue that's very poor at contracting and leads to reduction in the ejection fraction. Etiologies that are associated with a preserved ejection fraction account for the other half of total causes of heart failure. These will include concentric hypertensive cardiomyopathy, so the most common form of hypertensive heart disease with preserved ejection fraction. This accounts for the majority of cases of preserved ejection fraction heart failure. There's valvular diseases, particularly aortic stenosis and valvular regurgitation. There are high output states of heart failure. These are conditions that require the heart to work harder as a result of some secondary process, such as anemia, hyperthyroidism, pregnancy, the presence of an AV fistula, or beriberi, thiamine deficiency. There are infiltrative diseases of the myocardium, which make it stiffer and less easy to fill during diastole. These include sarcoidosis, amyloidosis, and hemochromatosis. There are pericardial diseases, which lead to a decrease in the pericardial compliance, which impair diastolic filling of the left ventricle. There is the genetic condition of hypertrophic cardiomyopathy, where a mutation in a structural protein such as troponin leads to abnormal concentric hypertrophy of the left ventricle. There's the glycogen storage defects, particularly Fabry's disease, and an eosinophilic infiltration of the myocardium as seen in Loeffler's carditis. Now, commonly you'll hear physicians describe cardiomyopathies in this category as leading to systolic dysfunction, whereas the etiologies in these categories are often referred to as causing diastolic dysfunction. These terms can be a little misleading because all causes that affect the systolic function of the heart also generally affect the diastolic function of the heart, and they usually go hand in hand. Whereas not all causes of preserved ejection fraction heart failure necessarily involve diastolic dysfunction, which is a more specific echocardiographic diagnosis. In particular, the high output heart failure states do not involve diastolic dysfunction. The function of the heart is relatively well preserved, but as a result of increased demand and workload on the heart, it may not be able to keep up. Now, when diagnosing heart failure, it's important to keep in mind that it is a predominantly clinical diagnosis based on an assessment of the patient's history with particular attention to specific clinical signs and symptoms. And the use of laboratory and imaging tests is primarily used to differentiate it from other etiologies that cause similar symptoms and to identify possible etiologies. So some of the symptoms we look for to identify a patient as having heart failure include, of course, dyspnea or shortness of breath, orthopnea, which describes the worsening of the shortness of breath when a patient lies down flat, and a phenomenon called bendopnea, which is when the symptoms get worse when the patient bends over, for example, to dress themselves or put on shoes. There's paroxysmal nocturnal dyspnea, or PND, which is when a patient reports abruptly waking up at night short of breath. There's leg swelling or peripheral edema, worsening exercise tolerance, chronic nighttime cough, depression, confusion, and syncope. While physical exam is increasingly considered much more unreliable in diagnosing heart failure, with even experienced cardiologists and clinicians having difficulty identifying some of the signs of heart failure on exam alone, some of the items to look for include jugular venous distension, or JVD, the hepatojugular reflux, which is when increases in the jugular venous pulse are appreciated with palpation, prolonged palpation of the liver, causing a reflux of venous blood. Listening for extra heart sounds, including the early diastolic S3 heart sound, which is indicative of systolic dysfunction, or the late diastolic S4 sound, which is more indicative of significant diastolic dysfunction. Looking at the patient's weight and noticing significant weight gain, appreciating peripheral edema, listening for lung crackles, noticing a narrowing of the pulse pressure, the difference between the systolic and diastolic pressures, and looking for the phenomenon of Cheyne-Stokes breathing, which is the phenomenon of progressive hyperventilation followed by periods of apnea, alternating again with hyperventilation. This is a finding seen as a result of defects in the central autoregulation of breathing in the respiratory control centers, particularly noticeable in patients with heart failure. The major tests and imaging that we order to confirm and help us make a diagnosis of heart failure include the natriuretic peptides, BNP, and the N-terminal proBNP, the ECG, a chest x-ray or other chest imaging, and an echocardiogram, usually a transthoracic echocardiogram. Thankfully, there are validated clinical criteria for making a diagnosis of heart failure. These include the Framingham criteria and the Boston criteria, both of which rely on physical exam and history features to give a likelihood of a patient having heart failure. In the Framingham criteria, a patient is considered to have heart failure if they meet any two of the major criteria listed here, or if they meet one of the major criteria plus any two of the minor criteria listed here. And if they meet those criteria without having any other alternative explanation for those same symptoms and signs, such as pneumonia or other lung disease. The Boston criteria incorporates not only history and physical exam features, but also findings seen on chest radiograph. A patient can get up to 3 to 4 points in each category, and the points are totaled up, and if the patient has 8 or more points across all categories, this is considered to be definite heart failure. Again, if there are no alternative explanations for the patient's symptoms. Now, identifying a patient and heart failure on the basis of a chest x-ray can be very tricky, so let's look at a few images. This chest x-ray shows a patient with bilateral increases in lung interstitial markings. You'll notice some very brightly opaque markings in the middle of the chest wall. These are sternotomy wires, which indicate that the patient likely had some kind of open heart surgery in the past, which is a big diagnostic clue here. And these arrows here point to tiny horizontal lines that come out from the lung periphery and extend inward. These are known as curly B lines, and they represent edema in the interlobular septa. These are considered a poorly sensitive but fairly specific marker of cardiogenic pulmonary edema. They're similar to, but not to be confused with, the B lines seen on lung ultrasound. These are the vertical shafts of light that project downward from the pleural line on a lung ultrasound. You'll see the pleural line on the lung ultrasound with bright projections or rockets that look like these. These are the B lines. These are also indicative of pulmonary edema on the lung ultrasound, but they're actually artifacts, whereas these actually have an anatomical correlate, which is the edema in the pulmonary interlobular septa. Here's a second image from a patient with heart failure. In this patient, you can clearly appreciate the cardiomegaly, the diameter of the heart. Takes up a significant fraction of the total diameter of the chest cavity. In this case, probably greater than 2/3 of that diameter, which is fairly significant. there are patchy opacities in the bilateral lungs. And you'll notice that the hyla are particularly full, but that the pulmonary vessels are especially prominent, pointing towards the apex of the lung. This is a phenomenon called cephalization, and it's particularly prominent in upright chest x-rays of patients with heart failure or x-rays taken while the patient is seated, and these represent the shifting of the pulmonary vessels upward towards the apex of the lung as a result of increased pressures in the lower dependent parts of the lung. Although CT scans of the chest are not generally part of the evaluation of a patient with heart failure, they can be often ordered in order to exclude other etiologies that might be causing symptoms that are similar to heart failure. In this image, taken as a sagittal view of a sagittal cut of the lung, you see again lines extending from the periphery inward. These are again representing the interlobular septa of the lung and correspond to the curly B lines. In this image, with a transverse cut of the lung, we see, again, thickened interlobular septa filled with pulmonary edema. We also see rings of pulmonary edema centered around the bronchi. This is a phenomenon called peribronchial cuffing and is often seen in patients with cardiogenic pulmonary edema as well. Finally, a common finding in patients with cardiogenic pulmonary edema are the presence of a pleural effusion. It's often unilateral and on the right side of the lung. The ECG is another test that by itself cannot make a diagnosis of heart failure, but is often ordered to look for potential etiologies and to give clues as to why the patient might be in heart failure. Some factors to look for are left axis deviation caused by left ventricular enlargement, dilation, or hypertrophy, left atrial enlargement as a result of increased left ventricular filling pressures due to the increased preload, left ventricular hypertrophy, poor R-wave progression. This is a sign of poor motion of the anterior wall of the heart and is seen in patients with significant reduction in their ejection fraction. And the presence of ventricular ectopic beats, which is, again, a common finding in patients with significantly reduced ejection fraction and reflects scar tissue in the ventricles that produce ectopic beats. This is an ECG of a patient with heart failure showing several of these features. We see prominent negative P waves in the lead V1, which indicates possible left atrial enlargement. The axis, while normal, as indicated by the positive QRS complexes in leads 2 and 1, the fact that the QRS is more negative in AVF tells us that the actual axis is between 0 degrees and negative 30 degrees. So definitely somewhat more on the leftward side while still being normal. The large S wave and R wave voltages in the precordial leads point towards left ventricular hypertrophy. The fact that the R wave is smaller than the S wave in leads V3 and V4 is also indicative of poor R wave progression. And we may look for ectopic beats. If we don't see them on an ECG, we may place the patient on a telemonitor, and we may find some ectopic beats there on the tele. A really important test that's ordered almost all the time in patients with heart failure or suspected heart failure are the natriuretic peptides, the brain natriuretic peptide or BNP, and the N-terminal pro-BNP. The brain natriuretic peptide is a peptide hormone that's released by the ventricles in response to excess stretch, which, as we discussed before, reflects increases in the preload as a compensation for the decreased contractility of the heart. The role of the brain natriuretic peptide is to induce the kidneys to promote salt excretion and relieve the stretch on the heart in order to decrease the workload of the heart. Essentially, high levels of BNP would tell the clinician that the heart is under a lot of stress and is trying to relieve some of that stress by getting rid of salt and water. N-terminal proBNP is a byproduct of the cleavage of the BNP precursor. The levels correlate to endogenous production of BNP by the heart. It's a similar concept to how C-peptide is a marker of endogenous insulin production in the pancreas. If the clinical diagnosis of heart failure is uncertain, you can use either of these or both of these hormones in order to help rule in or rule out heart failure. Usually we say that BNP levels less than 100 picograms per milliliter rule out heart failure, whereas BNP levels greater than 500 would rule in heart failure. For N-terminal proBNP, the cutoffs are age-dependent, less than 125 if the patient's less than 74, and less than 450 if the patient is greater than 74. There is a natural enzyme produced in the body called neprilysin that degrades BNP but does not have any effect on N-terminal proBNP levels. Since there is a new heart failure drug called sacubitril that does inhibit the neprilysin enzyme and raise BNP levels, this will lead to an artificial raising of the BNP that's unrelated to left ventricular stretch. But in these patients, you would use N-terminal proBNP. Patients on this drug, you would use N-terminal proBNP rather than BNP levels to as a marker for worsening heart failure. Here's a diagram of how N-terminal proBNP and BNP fit together. So inside the cardiac myocytes, there's a gene called the NPPB gene. This is the transcription of this gene is increased whenever the cardiac muscles are under stretch, also when they're under influence of certain hormones and hypoxic. In these situations, the propeptide, proBNP1-108, is produced. It's then cleaved to form the biologically inactive N-terminal proBNP, which is released into the blood but doesn't do anything, and the biologically active BNP, which then goes on to act on the kidney to promote salt excretion. After a little while, the enzyme neprilysin cleaves the BNP at various sites to render it inactive. Although we tend to depend very highly on BNP to either make or rule out the diagnosis of heart failure, it's very important to recognize that there are many causes of BNP elevation that are unrelated to heart failure. These include acute coronary syndrome, atrial fibrillation, advanced age, renal failure, severe anemia, a pulmonary embolism where markedly elevated BNP levels are actually a highly negative prognostic marker and actually affects management, severe lung disease or ARDS, liver failure, and finally, a condition that actually will falsely decrease the levels of BNP is obesity. In morbidly obese patients, you should set somewhat higher cutoffs to exclude heart failure as a cause of elevation of BNP. Some other common diagnostic tests that are ordered in patients with heart failure include the BNP, or basic metabolic profile, where you would order this to assess the patient's baseline renal function, potassium level, and calcium level. This is particularly important as diuretics are a major part of their therapy, and they would affect all of these parameters. A CBC is ordered to check for signs of infection or anemia, which would be contributing to high output heart failure and might alter the BNP levels. LFTs are checked as direct bilirubin is one of the earliest things to rise in congestive hepatopathy as a result of heart failure. TSH, a lipid profile in A1C to look for risk factors, some of the most common risk factors contributing to heart failure, which can be treated. A urine drug screen, an alcohol level to look for causes of cardiomyopathy that might be drug-related. And the D-dimer or CT angiography of the chest or VQ scan, basically to rule out PE, depending on the patient's Wells score, as a cause of the patient's symptoms. We'll next go on to discuss heart failure therapies, particularly the therapies for heart failure with reduced ejection fraction. When discussing these therapies, we often find that these therapies are used to prevent cardiac remodeling. So, in order to understand what that is, let's discuss how the heart responds to normally to stress, injury, or other conditions that are associated with increased workload. Just like any other muscle, when the heart is under increased workload, it tries to compensate by increasing the number of myocytes present, a process called hypertrophy. Generally, when the heart experiences a gradual increase in workload over time, it tries to compensate in a more efficient manner called concentric hypertrophy. This is when the new myocytes that are produced are paired in parallel with the existing myocytes. This leads to a thickening of the ventricular wall and produces much more efficient contractions. These efficient contractions allow the heart to preserve its ejection fraction while providing adequate perfusion to the body. Now, either when the insult or increase in workload of the heart is very acute, or when the heart is no longer able to compensate as a result of many, many years of increased stress and work, it progresses from concentric hypertrophy to eccentric hypertrophy, which is when the cardiac myocytes no longer are paired in parallel, but now in series. This leads to an increase in the diameter of the heart and a dilation of the left ventricular chamber. While this does allow the heart to accommodate an increased preload, increased end diastolic volume as a result of increased chamber size, the contractions created by muscle cells paired in series rather than parallel is much, much less efficient, and that leads to decreased ejection fraction. Whereas with the compensated concentric hypertrophy, we saw preserved ejection fraction. So let's discuss some of the medical therapies that we use to have mortality benefit in these patients and prevent remodeling. We'll go through the evidence-based examples of drugs in each class, the indications for their use, some of the adverse side effects to watch out for, the positive effects, and at the bottom here we'll mention the landmark clinical trials that showed their benefit in heart failure. First, there's the class of ACE inhibitors, which would include lisinopril, enalapril, and ramipril. Most heart failure patients should be on these medications. Some of the adverse side effects to use of these medications include cough, angioedema, increase in serum creatinine by around 30% from the patient's baseline, and hyperkalemia. They are very effective at preventing cardiac remodeling. An alternative to ACE inhibitors are the angiotensin receptor blockers, or ARBs. Some examples include losartan and valsartan. These are mainly used when a patient can't tolerate ACE inhibitors as a result of cough or angioedema, as ARBs are much less associated with these as a result of having a decreased effect on bradykinin. These also will cause increase in serum creatinine and hyperkalemia and are effective at preventing remodeling. Beta blockers, specifically carvedilol, metoprolol succinate or metoprolol extended release, and bisoprolol, are also given to all patients who can tolerate them. They're associated with a number of adverse side effects, however, including fatigue, depression, and masking of hypoglycemic symptoms. These do also prevent cardiac remodeling. You do have to watch out for bradycardia or AV block, which can be one of the major contraindications to their use. The aldosterone antagonists, spironolactone and eplerenone, are indicated in patients with NYHA class 2 through 4 heart failure who have potassium levels less than 5 and relatively okay kidney function with a GFR greater than 30 milliliters per minute. The side effects include gynecomastia specific to spironolactone and hyperkalemia, as they are potassium-sparing diuretics. A relatively newer class of medications that have shown to have enormous benefit in patients with reduced ejection fraction heart failure is the combination of an angiotensin receptor blocker, valsartan, and the neprilysin inhibitor, sacubitril. This is marketed under the brand name Entresto, and it's indicated in patients who are able to tolerate ACE or ARB therapy without any hypotensive symptoms. Increasingly, it's being used as first-line therapy without waiting to start ACE inhibitors or ARBs separately. You would either have the patient on this or one of these, but not both. Patients who are being switched from an ACE inhibitor to the angiotensin-neprilysin inhibitor combination should wait at least 36 hours after stopping the ACE inhibitor before starting the sacubitril valsartan. Arterial vasodilator, specifically the combination of hydralazine and isosorbide dinitrate, are used as alternatives to ACE inhibitors, particularly in Black patients with heart failure and those who can't tolerate ACE inhibitors or ARBs, often as a result of poor renal function or hyperkalemia. Finally, there is the funny channel blocker, ivabradine. This is indicated to reduce hospitalizations, but it only can be used in patients with ejection fractions less than 35%, with heart rate greater than 70 despite being on the maximum tolerated dose of beta blocker, and who are in sinus rhythm, as one of the major side effects of this drug are precipitation of arrhythmias such as atrial fibrillation. It's thought to help cardiac function by helping to slow down the heart rate, decreasing the automaticity of the pacemakers, and increasing diastolic filling time of the ventricle. In addition to these more traditional therapies, there have been some relatively recent advances in heart failure management as a result of recent trials that have come out. First is the DAPA heart failure trial published in the New England Journal of Medicine in 2019. This suggested that the addition of the SGLT2, sodium glucose transporter 2, Dapaglifozin, to the standard heart failure regimen in patients with ejection fractions less than 40% significantly decreased cardiovascular mortality and hospitalizations and symptoms compared to placebo. And while you might think that the beneficial effect of this medication was due to its ability to lower glucose and control diabetes, which is a major risk factor for heart failure, it was interesting to note that this protective effect on the heart was even seen in patients who did not have diabetes. Some of the proposed mechanisms for why this was included the idea that the use of the sodium glucose transporter inhibitor promoted sodium loss in the kidneys, which would help decrease the workload of the heart, just like a diuretic, and also that it improved energy metabolism as a result of improved glucose regulation, and finally that it increased renal uric acid excretion, as uric acid is thought to be a major contributor of atherosclerosis. More recently, a trial was published studying the role of the nitric oxide stimulator Vericiguat would significantly improve symptoms and mortality in patients with heart failure. The theory behind this was that dysfunction of the nitric oxide pathway in vascular smooth muscle was thought to be a major contributor to heart failure symptoms. They noted that patients with heart failure tended to have much lower levels of endogenous nitric oxide than patients without heart failure. And cyclic GMP, a small molecule signaling agent, helps regulate smooth muscle in response to nitric oxide stimulation. So in the recent Victoria trial, published in March 2020 in the New England Journal of Medicine, showed that the addition of this guanylate cyclase stimulator Vericiguat in patients with EF less than 45% and recent CHF exacerbations reduced the incidence of further hospitalizations and mortality. Here's a diagram of how Vericiguat is thought to work. In patients with heart failure, they noted, as I said before, a decrease in endogenous nitric oxide production, which leads to myocardial dysfunction and vascular dysfunction. Vericiguat, by directly stimulating guanylate cyclase, increases the levels of cyclic GMP, which help to reverse the vascular dysfunction. So these therapies seem to be fairly effective for patients with reduced ejection fraction, but what about patients who previously had reduced ejection fraction but noticed a significant improvement in their ejection fraction, likely as a result of consistently taking the aforementioned medical therapy? These are patients who are said to have heart failure with recovered ejection fraction. And an important question that was asked is, should these patients whose ejection fraction has now recovered continue taking their previous heart failure therapy, or can it be safely stopped? Well, this question was addressed in the recent trial published in Lancet called TREAD, and it showed that continuing medical therapy for heart failure in patients with recovered ejection fraction actually did show benefit and decrease the risk of them relapsing back into reduced ejection fraction. Electrical or device therapy has increasingly become a mainstay of treatment of patients with heart failure. The options that are used are the implantable cardioverter defibrillator, or ICD. As I mentioned before, patients with reduced ejection fraction as a result of their myocardial scarring are increasingly prone to develop ventricular arrhythmias, starting with premature ventricular beats, and then progressing to likely fatal episodes of VT or VF. So it's recommended that in patients with ejection fractions less than 35% that has persisted despite 3 months of optimal medical therapy should be referred for ICD placement. It's not recommended to place an ICD in a patient within 40 days following a myocardial infarction and within 3 months of any coronary revascularization. The second therapy that's thought to be very effective in patients, in certain patients with heart failure, is the cardiac resynchronization therapy, or CRTD, also termed the biventricular pacemaker with defibrillator. This is indicated in patients, again, who meet the same criteria as ICD placement, but also have either a left bundle branch block morphology on their ECG with a QRS wider than 150 milliseconds, or a QRS wider than 180 milliseconds with any non-left bundle branch block morphology, such as a right bundle branch block. Finally, it's also indicated in those patients with advanced AV block who are highly pacemaker dependent, regardless of their symptoms. The principle of this therapy is that patients with either a left bundle branch block or those requiring a high burden of right ventricular pacing experience that their right ventricle is contracting earlier than the left ventricle. And because of this dyssynchrony between ventricular contraction, that actually leads to worsening cardiac remodeling, and it makes it much, much harder for the patient's ejection fraction to improve, and may actually make the ejection fraction worse. So, in order to help to bring the ventricles back in sync with each other, one pacemaker lead is inserted into the right ventricle as normal, whereas a second pacemaker lead, a much thinner one, is threaded through the patient's coronary sinus and sits on top of the left ventricle epicardium, and both of these leads depolarize essentially simultaneously so that the ventricles contract simultaneously. Now, what about our patients with Class D heart failure, where medical therapy and device therapy alone are not enough to control their symptoms? These are patients who need to be referred for more advanced therapy, and the mainstay of advanced therapy for Class D patients are the ventricular assist devices, or VADs. Although not strictly speaking, a VAD itself, the precursor to this kind of technology was the intra-aortic balloon pump, which is shown here. This is a balloon that's attached to a catheter that's threaded up through a femoral artery into the aorta. The balloon inflates during diastole and deflates during systole. The deflation during systole allows blood to flow normally through the aorta and perfuse the body in systole. When the heart's not pumping in diastole, the balloon inflates, which then helps to provide additional force to push blood to perfuse the arms and brain, as well as to push blood backwards to supply the coronary vessels, which come out of the coronary cusps of the aortic valve. In addition to increasing coronary and brain perfusion during diastole, this has the added benefit of decreasing afterload. A more advanced device is the Impella. This is a device that's similarly threaded through a patient's artery, enters the left ventricle through the aortic valve, and sits inside the left ventricle. And it essentially functions as a pump. It pulls blood inward from the left ventricle and then pushes it out directly into the aorta, completely bypassing the need for ventricular contraction. It's able to take over essentially all of the workload of the left ventricle, and as such, the patients with this device don't have regular pulses, since the blood is continuously being pumped from the ventricle into the aorta. Finally, there is the surgically placed implanted LVAD device. This consists of tubing that pulls blood from the left ventricle, runs it through a pump, and then pushes it out directly into the aorta. This is completely external to the heart, although surgically implanted in the patient's body, unlike the Impella device, which is following the normal vasculature of the patient. Here's a table summarizing some of the ventricular assist devices that are currently in use and their indications. You see the Impella LVAD here, which provides full cardiac output. There are similar devices called RVADs, which are useful for patients with right ventricular failure. And in the most advanced cases, as usually used as a temporizing measure, is venous arterial ECMO, or VA ECMO, where blood is pumped directly out of the femoral vein, run through an artificial oxygenating machine, and then pumped back in through the patient's artery. This provides not only full cardiac support, but also provides full oxygenation support. So it completely bypasses the patient's heart and lungs. And it's very useful in patients who have significant cardiac and pulmonary disease, such as ARDS with cardiogenic shock. Now, the beta agonist dobutamine and the phosphodiesterase 3 inhibitor milrinone can be used as continuous inotrope therapy. It's indicated in patients with stage D heart failure who are either awaiting a device or a transplant. And it can be also used palliatively in patients who are not candidates for a VAD or transplant, but are having limiting symptoms, and where the addition of an inotrope may help them to regain some of their functional status. We also do use it short-term in hospitalized patients with very low EF heart failure who are borderline hypotensive or hypotensive and have laboratory evidence of decreased end organ perfusion, such as lactic acidosis or increase in their serum creatinine. Here's a summary table of management strategies for chronic heart failure as published by the American College of Cardiology. Just to review, when we diagnose a patient with reduced ejection fraction, regardless of their NYHA class, they should be started on an ACE inhibitor or angiotensin receptor blocker, in addition to a beta blocker, provided they don't have any contraindications, such as hyperkalemia or hypotension or poor renal function for either the ACE inhibitor or angiotensin receptor blocker, and no hypotension or AV block or bradycardia for beta blocker use. If they do meet the criteria for starting an aldosterone antagonist, you would start that as well. If they're good candidates for Entresto, the sacubitril valsartan combination, you might just consider not giving them ACE inhibitors or angiotensin receptor blockers and starting straight away with that medication. Or otherwise consider switching patients who have chronically been on angiotensin receptor blockers or ACE inhibitors to the sacubitril valsartan combination. Black patients or patients who can't tolerate ACE inhibitors or ARB as a result of their renal failure or hyperkalemia should be started on the combination of hydralazine and isosorbide dinitrate. Patients with a low ejection fraction who are more than 40 days after an MI and don't show improvement in their ejection fraction despite at least 3 months of goal-directed medical therapy should have an ICD placed. Patients who meet the indications for biventricular pacing should have that placed. And patients who meet the criteria for the funny channel blocker ivabradine should be started on that. When medical therapy has failed to control the patient's symptoms, we say that the patient is in ACC stage D heart failure. These patients should either be referred for a left ventricular assist device, transplant, or if they're not candidates for either, they should be referred for palliative care as the prognosis is very poor. And some of these patients may be candidates for home inotrope therapy, such as milrinone. Moving on from chronic heart failure to acute decompensated heart failure, or the heart failure exacerbations, it represents a common inpatient diagnosis. This is when the patient experiences an acute worsening of their heart failure symptoms, such as worsening leg swelling, dyspnea, worsening urine output, weight gain, nausea, or anorexia as a result of some trigger. This represents a very big diagnostic dilemma, as many of these symptoms might be indistinguishable from lung diseases such as pneumonia, COPD exacerbations, and an acute pulmonary embolism. And sometimes patients may wind up being treated for multiple conditions at once. Some of the common reasons that a patient might go into a heart failure exacerbation might include acute coronary syndrome, non-adherence to medications or diet, or perhaps not being on the right regimen of medications. Note that in order to be considered being on optimal goal-directed medical therapy, a patient should not only be on the right type of medications that are indicated for their condition, but also should be on the maximal tolerated dose. Sepsis and other infections can be a leading cause of heart failure exacerbation. Uncontrolled hypertension as a result of significant increase in the LV afterload would cause an exacerbation. Recreational drug use, medication side effects, particularly from NSAIDs and steroids, COPD exacerbations, various arrhythmias, and acute pulmonary embolism and acute renal failure can all be causes of exacerbation. A major challenge for clinicians, particularly cardiologists and outpatient physicians, monitoring their patients with heart failure was to find a way to identify patients who might be prone to going into an exacerbation earlier on, even before they started to develop symptoms. And so several strategies have been developed to address this concern. An early focus was, since many of these patients had ICDs and pacemakers being placed to prevent arrhythmias, we might be able to use these devices themselves to directly monitor a patient's volume status. One effective approach was to measure the patient's thoracic impedance, which is the resistance to electrical flow from the pacemaker canister located outside the chest wall to the pacemaker leads located inside of the chest wall. It was noticed that the more fluid that built up in a patient's lungs, the lower the resistance to electrical flow through the pacemaker wires was. And this reflects the fact that fluid tends to be a much better conductor of electricity than air. So by correlating the patient's thoracic impedance measurements as measured by their implantable devices, we could identify how much fluid was in their lung. Other pacemaker brands have tried to listen for the S3 heart sound as a clinical correlate of a patient's worsening heart failure. More recently, it's been proposed that we could directly record the pulmonary artery pressures used by use of an implantable device, and this would give us a sense of how much the filling pressures in the left ventricle were increasing over time. This is called the CardioMEMS device, or implantable PA pressure monitor, and it can directly record the patient's pulmonary artery pressures and transmit them to a physician for rapid interpretation and adjustment of management. Here's a graph showing thoracic impedance measurements over time in a patient with an implanted cardiac device following an episode of heart failure. You see that this device was implanted while the patient's thoracic impedance was fairly low, so this was likely during an exacerbation. As a result of good medical therapy, the thoracic impedance increased over time, reflecting the drying out of the patient's lung. Then the patient came back to the hospital with another exacerbation, and the device was interrogated and its thoracic impedance was recorded. And you see that 28 days prior to hospitalization, there was a gradual drop in the thoracic impedance, reflecting the fact that the patient was developing pulmonary edema. In this case, by using this information, the clinician was able to determine that the patient ran out of their medication 1 month ago, and as a result was gradually developing worsening symptoms as a result of abruptly stopping diuretic therapy. However, if the patient's primary care physician or cardiologist had been able to pick up on the initial decline in the thoracic impedance, maybe around day 21 or 14 prior to admission, they might have been able to adjust the patient's outpatient diuretic therapy and prevent the onset of symptoms that led to the hospitalization. Here's an image showing the CardioMEMS device or PA sensor. It's implanted directly into the patient's pulmonary artery and continuously records the pressure in the pulmonary artery and transmits it to the patient's cardiologist or primary care physician, who can, again, similar to the thoracic impedance measurement, make adjustments to the patient's outpatient therapy and possibly prevent hospitalizations. So whenever a patient presents to the hospital with a heart failure exacerbation, we try to group them into one of several hemodynamic categories. And that's given by this traditional diagram here. We classify patients as being warm-dry, warm-wet, cold and dry, or cold and wet. What we mean by cold are those patients who have evidence of end-organ hypoperfusion. This can be reflected by findings such as hypotension, a narrowing of the pulse pressure, which reflects decreased stroke volume and cardiac output, cool, clammy extremities, delay in capillary refill, symptoms of altered mental status and dizziness, which reflect decreased perfusion to the brain, decrease in the urine output, or changes in the serum creatinine, which would reflect decreased perfusion to the kidneys, lactic acidosis, which reflects global hyperperfusion, and a direct echocardiographic assessment of the cardiac output as reflected by the left ventricular outflow tract volume time integral, or VTI. Patients without these features are said to be warm, whereas patients with multiple features in these categories are said to be cold. Contrast, the patients who are said to be wet have evidence of congestion. These include hearing pulmonary rales on auscultation, seeing evidence of orthopnea or paroxysmal nocturnal dyspnea in their history, seeing findings of congestion on the chest x-ray, which, as we discussed previously, could include pleural effusion prominently on the right side, cephalization of the pulmonary vessels, presence of curly B lines, and bilateral infiltrates. Hypoxia reflects elevation of the A gradient as a result of pulmonary edema. And on echocardiography, an increase in the early diastolic mitral inflow velocity, E, to the early diastolic mitral annular relaxation velocity, or E prime. If this ratio is greater than 14, that generally reflects increase in left-sided filling pressures, or left atrial pressure. There's also findings of JVD, or hepatojugular reflux, leg swelling or weight gain, and ascites or hepatomegaly, with an echocardiographic finding of a dilated, non-collapsing inferior vena cava, or IVC. These particular findings are associated with increase in left-sided pressures left atrial pressures, whereas these findings are associated with increase in the right-sided pressures. In addition to classifying patients by their hemodynamic status, we also have a practical phenotypic classification, which includes 5 different categories of acute heart failure. These are the patients who are in complete cardiogenic shock with hypotension and evidence of end-organ hyperperfusion. The patients who are normotensive and wet. This is the most common classical form of acute heart failure. Patients who are in a hypertensive emergency with a marked increase in their afterload. Patients who are in acute right-sided heart failure who have the findings of right-sided congestion without significant findings of left-sided congestion. And patients who are in heart failure as a result of acute coronary syndrome. When treating patients with heart failure, it's important to classify patients into these categories in order to decide the most appropriate management. First, we would classify the patient's hemodynamic status. Are they warm, wet, cold, or dry, based on their vitals, physical exam, and other non-invasive testing methods, which can include echocardiography at the bedside. Any patients who are cold, showing evidence of organ hypoperfusion, and those patients with acute respiratory failure will often require ICU-level care for inotropes and ventilator support, whereas patients who are warm can often be managed in a cardiac telemetry unit. And it's critical to identify early some of the most dangerous precipitating causes of heart failure and also exclude other etiologies that may be contributing to a patient's symptoms. These would include acute coronary syndrome, an acute pulmonary embolism, arrhythmia, sepsis, or COPD exacerbation, or an endocrine disorder. Let's start with the management of the patients who are classified as warm and wet, the normotensive patients. These are the classic textbook heart failure exacerbation patients who represent the majority of our inpatient heart failure exacerbations. For these patients, we start by initiating diuretic therapy at 3 times the patient's home daily dose, or if they're not already on diuretics, we would start furosemide IV at 1 milligram per kilogram, usually divided into twice daily or 3 times daily doses. You can also add the thiazide diuretic metolazone, 5 milligrams given 5 to 10 minutes prior to the administration of a loop diuretic, and the combination of a thiazide and loop diuretic would have a synergistic effect, which would promote diuresis. You might consider halving the dose of the patient's home beta blocker and avoiding all of their nephrotoxic agents while a patient is being diuresed. And it's very important to monitor the patient's daily weights, intake and output, which would include all the total volume of water and other fluids that the patient has been drinking over the course of 24 hours, and their complete urine and stool output. We also keep close track of the patient's serum creatinine and serum electrolytes, as high-dose diuretics can greatly affect these lab values. Once the patients start to improve and the patient has been in negative fluid balance for a period of time, you can resume the patient's home dose of heart failure medications and switch them back to PO diuretics. You might want to consider increasing their home dose of diuretics by 1.5 to 2 times, particularly if you think that the patient had been underdosed at home. When it comes to diuretic dosing, keep in mind that furosemide in its IV form is 2 times stronger than the PO form. Torsemide is a stronger loop diuretic, which is even 2 times stronger than the IV form of furosemide, or 4 times stronger than the PO form of furosemide. And bumetanide is the most potent loop diuretic, which is 40 times stronger than IV furosemide. Again, metolazone can be given for synergistic effect. And the very important dose trial published in the New England Journal of Medicine in 2011 showed that we should not be afraid to start high-dose diuretics early in most patients with warm and wet hemodynamics. This study compared high-dose and low-dose strategy for diuresis in these patients and found that there was no significant difference in electrolyte abnormalities and long-term changes in renal function as a result of giving high-dose diuretics. In fact, the higher dose strategy actually led to decreased length of hospital stay. The next group of patients in heart failure, the second most common type we'll see in most of our inpatient admissions, are the patients who are warm and dry. A special name has been given to this phenotype of heart failure, which is called sympathetic crashing acute pulmonary edema, or SCAPE. Some clinicians classify this phenomenon as completely separate from acute heart failure exacerbation, while others consider it to be a separate phenotype within the wider scope of an acute decompensated heart failure. The distinction here is that these patients don't have a significant issue with increased volume or preload, but they are developing pulmonary edema as a result of marked increase in left ventricular afterload, which leads to difficulty in the heart pushing blood forward and leading to the heart increased pressures in the left atrium and the pulmonary veins, leading to pulmonary edema. And so rather than diuresing these patients, all you really need to do is control their blood pressure, reduce the cardiac afterload, and their symptoms should quickly resolve. In order to do this, we try to control their blood pressure with afterload reducing agents, using a strategy similar to what we use in hypertensive emergency, 25% reduction in the first couple of hours, and return to normal tension within 24 hours. Some of the agents we use to achieve this are IV nitroglycerin, PO hydralazine, and sublingual captopril, which is a very effective short-acting ACE inhibitor, which is ideal in patients without significant renal impairment and with normal potassium levels. Rather than reducing or stopping the patient's home beta blocker, you would continue their home beta blocker at full dose, since your goal is actually to reduce the sympathetic tone of the patient. The use of positive pressure ventilation is very effective in these patients as it leads to combined preload and afterload reduction. Note that it's contraindicated to use non-invasive positive pressure ventilation such as CPAP or BiPAP in patients with acute hypercapnia, patients who are altered as they may aspirate and develop severe pneumonias, and those with heavy secretions. For these patients, you should consider direct intubation rather than non-invasive ventilation. And again, these patients really need to have their afterload controlled, whereas their preload status is usually normal. So you would avoid aggressive diuresis unless their blood pressure remains high and their symptoms persist after you've taken all the previous steps. Now, positive pressure in particular is a very effective strategy for patients with warm and dry heart failure, mainly because of its beneficial hemodynamic effects. So it decreases the preload in the right ventricle by increasing the intrathoracic pressures and limiting venous return. It increases the RV afterload by increasing the pressure in the lungs so that the right ventricle has to work much harder in order to push blood into the lung. It decreases LV preload over time as less blood is flowing from the right side of the heart into the left side of the heart as a result of the combination of the decreased RV preload and increased RV afterload. And finally, and most notably, it decreases the LV afterload. You can think of the positive pressure as giving an extra squeezing force on the heart and making it easier for the heart to start pumping blood out into the aorta. Since decreasing LV afterload and decreasing LV preload are two of the most important things to keep in mind when treating heart failure, and since non-invasive positive pressure is one of the only modalities that does both together, it is very effective. Moving on to the patients with cardiogenic shock, these are the patients who are cold and either wet or dry. These patients, you should initially start by checking for fluid responsiveness using a variety of methods. One of the most effective ones is the passive leg raise maneuver combined with a bedside ultrasound assessment of their stroke volume variability. If you find that they are fluid responsive, you can give small fluid boluses, say like 250 to 500 cc's, if you and looking for improvement in blood pressure. You should try to place a central venous line and an arterial line to monitor the blood pressure as soon as possible. And once they're no longer responding to fluid boluses, start a norepinephrine infusion. This is the first-line agent in cardiogenic shock. You titrate this to achieve a mean arterial pressure greater than 60. As an adjunct inotropic agent, you can add either dobutamine or milrinone and titrate to a central venous oxygen saturation, which is measured from a venous blood gas taken directly from the central line, greater than 70%, looking for sustained improvements in the patient's serum creatinine, or titrating to a cardiac index as measured from either a fixed equation or through a bedside ultrasound assessment using the patient's left ventricular outflow tract volume time integral, greater than 2 liters per minute per meter squared. You would intubate patients for refractory hypoxia and high worker breathing. Now, patients with acute decompensated heart failure as a result of ischemic cardiomyopathy do need early recognition, as the only definitive treatment for this is urgent revascularization. So this is one of the big reasons we do tend to follow serial ECGs and troponins in patients with heart failure to identify and treat these causes. Patients with isolated right-sided heart failure, usually characterized by edema and JVD with normal or lower than expected left-sided pressures. You should consider causes of these to include acute pulmonary embolism, a right-sided infarct, or a acute lung pathology such as a COPD exacerbation or pneumonia. In these patients, it's very important to avoid aggressive diuresis, as right ventricular failure is a highly preload dependent state, and you should be targeting actually a high normal CVP of 8 to 12 millimeters of mercury in order to ensure that the patient doesn't acutely become hypotensive as a result of hypovolemia. However, it is very important to try and reduce RV afterload as much as possible, and this can be achieved by the use of inhaled pulmonary vasodilators such as inhaled nitric oxide and inhaled epoprostenol. We'll finish off with a sample plan summarizing the management strategies in patients who present with acute decompensated heart failure. Diuresis should be initiated in your patients who are warm and wet. You would use IV furosemide or the equivalent at 3 times the patient's home dose, usually whichever is larger. You'd not be administering any diuretics for patients who are in cardiogenic shock or who are dry. Try to monitor daily weights, intake and output, and aim for a negative fluid balance of -1 liter. Patients who are wet, you would try to restrict their volume status by limiting them to less than 1 liter of fluid intake. That includes water, juices, sodas, over the course of 24 hours. In patients who are warm and dry particularly, but also to some extent in patients who are warm and wet, you would be using strategies to reduce their left ventricular afterload using hydralazine, nitrates, ACE inhibitors or angiotensin receptor blockers, and calcium channel blockers. You would not be administering these medications to a patient in shock, as these are all agents that will lower the patient's blood pressure. Beta blockade should halve the dose for moderate exacerbations, those patients who are warm and wet, hold them in shock, and continue full dose in patients who are warm and dry. We'd consider inotropic support with milrinone and dobutamine as an adjunct to norepinephrine for cardiogenic shock. Give supplemental oxygen as needed to maintain saturation greater than 92. Consider positive pressure ventilation, such as CPAP, for patients in respiratory distress, particularly those patients with a warm and dry phenotype. We'd almost always obtain at least a transthoracic echocardiogram to assess the patient's EF, which would dictate further management strategies, and to look for contributing etiologies such as new structural heart disease, wall motion abnormalities, or valvular disease. Finally, we would be aggressively looking for and trying to address any precipitating etiologies or emergent things that need to be addressed, such as acute coronary syndrome, pulmonary embolism, arrhythmias, and RV failure and noncompliance with medications. And that concludes my lecture on heart failure. I hope you enjoyed. Thank you so much and have a great day.